Thank you very much for inviting me to give this talk on the role of radiology in sepsis in the Sepsis Pocketbook. My name is Lowell. I'm an assistant professor from the Chinese University of Hong Kong, working in Hong Kong. So for the next 20 minutes or so, we're going to talk about the role of radiology. And as you can see here, there's a silhouette of Sherlock Holmes. And I'm sure by the end of the talk, you'll understand why he's here. So a bit of conflict of interest. I'm supported by the Hong Kong government for some of my research. And also I've taken some consultancies from MSD on treatment of infections. So a brief overview of what we're going to talk about today. Number one, we're going to talk about, of course, the role of radiology in sepsis. What are some of the different diagnostic modalities that are available to us, and the therapeutic roles that radiology plays in sepsis management. So this is a picture of Superman, and we all want to have X-ray vision like him. If we could have X-ray vision, we can then just have radiology in our eyes and look at patients in a completely different way. And in some ways, we do need that in management of sepsis. And the reason is because a lot of patients are looking like this, where they're intubated, they're sedated, they're extremely sick, and they're really unable to give a history. Time is of the essence to try to find the cause of their deterioration. And of course, the most concerning in sepsis is whether they have an infection or where's the infection. And sometimes they present so late in their symptoms or so acute that they have multi-organ failure. And actually, every single organ is affected, and we don't know which one is the culprit one that is affected by the infection. And that's why radiology, going back to Superman, is going to try to help us find the infection focus and hopefully obtain source control and select the appropriate antibiotics to fend off the infection. And in some ways, we did some work in this area trying to look at the radiology's role in sepsis. This is a scoping review done by our group. We found that when investigating for sepsis of unknown origin, that's to say that you don't know where the sepsis or the infection is coming from, but you think the patient's infected, 64% of the articles that we found in the scoping review actually mentioned radiology as part of the workup. And in fact, actually was the highest modality or part of the diagnostic arsenal compared to history, examination, other investigations. Radiology almost always comes up on top as the more frequently used diagnostic tool. So we really have to be a bit like Sherlock Holmes when we're managing patients with sepsis, because we're trying to find the infection focus. As we discussed that, sometimes the history, the examination, or the blood results are not very revealing in terms of where it's coming from. So now we'll get to the crux of the matter is what is the role, or why is radiology important in terms of sepsis management? Well, number one, it helps us identify the site of infection. And unlike Superman, who can just look through X-ray vision and identify fractures or infection sites, we don't have that skill, and that's why we rely on machines, radiation, and also different contrast to help us. It's also to assess the extent and severity of the infection. For example, we might want to look at where are the abscesses, how many there are, what's the size, and also whether there are multiple sites which are infected. It's also to help us identify alternative diagnosis. And this is something that we'll talk about shortly when we share some of the images. But someone who comes with multi-organ failure, dyspnea, abdominal pain, there may be other diagnoses apart from pneumonia or intra-abdominal collections or UTI that we might have to be concerned about. And so radiology can help us look at and consider other diagnoses which may not be sepsis or infection related. In fact, prospective studies have shown that people who we think originally had sepsis on IC admission actually turn out not to have sepsis. And this is quite a significant proportion. Up to about 20 to 30% don't have sepsis and have an alternative diagnosis established, or up to another 20 to 30% actually have culture negative sepsis. That's to say that we think the patient has an infection, but we just either can't grow the bug or we can't ID the bug or do serology tests, and nothing revealing comes from to reveal what is the pathogen. Radiology is also extremely important in helping guide where to drain fluid collections, help put in needles safely to guide drainage of abscess percutaneously without needing to do extensive open surgery. It's also extremely helpful in terms of helping us to monitor the patient's treatment response. And so we all know patients treating with pneumonia on ICU, sometimes we repeat the radiology imaging, either by radiographs or CT imaging, to see whether there's resolution of the infiltrates as a guide to say, okay, the patient perhaps may be responding to our antimicrobials, or if we require some drainage in the abdomen, for example, of pockets of abscess, a repeat CT after drainage or antibiotic therapy would be helpful in terms of assessing whether there's anatomical changes to or response to our treatment. So next, we're going to move on to some specific radiological modalities which can help us in sepsis management. The most common, of course, is the plain radiograph, which is extremely quick, portable, commonly available, low cost, and is not operator dependent. Of course, it's slightly operator dependent in terms of you trying to make sure you get the view or the field of view within what you're interested in on the radiograph. But apart from that, the radiological interpretation is really up to the clinician and also the radiographer or radiologist looking at the film. It's not very sensitive or specific, and that's one of the key problems with it. So, for example, the chest X-ray that we see here, although it looks very low bar, but the left side of the chest is also infiltrated. So this could really be chest infection, pulmonary edema, or it could even be some forms of ARDS, secondary ARDS from somewhere else, from the body, for example, a perforated bowel. So one of the problems with radiograph is you might see an abnormality, but you might not be able to tell extremely accurately what that abnormality may or may not be due to infection. So some key things otherwise that plain radiographs are also very good for would be looking at abdominal free gas and a direct chest X-ray, looking at pleural effusions, blunting of the diaphragms, pneumothoraxes. But in general, this is just a very quick screening tool to look for whether there's something wrong. Next, of course, we must come up to another tool, which is using essentially stacks of X-rays, which is computer tomography or CT. And the key differences here is that you're able to do really detailed cross-sectional views or reconstruction views. And you can delineate the anatomy really quite well with much higher sensitivity and specificity than plain radiographs for detecting abnormalities. And so a lot of studies have been showing that actually plain radiographs are not very sensitive in terms of picking up abnormalities such as chest infiltrates. And CT is far, far, far superior for detecting subtle abnormalities not picked up on radiographs. One of the problems is that it's not as commonly available as the chest radiograph. It's also not portable. You need to transport the patient to the CT suite. There's, of course, a much higher risk of radiation and also a risk of AKI if you are using contrast. But if you don't use contrast, one of the problems is that you might not be able to differentiate places which are inflamed or walled off abscesses quite well. And so the risk of AKI, although is overstated, does exist, and it may be a risk that the critically ill patient has to take just to identify or better delineate whether there's an infection focus. The CT image on the left side here is just showing free gas in the abdomen, pneumoperitoneum. As I mentioned earlier, chest radiographs, although they are good at picking up free gas, and once you see free gas, there's no question there is a perforated bowel or gut. In terms of sensitivity, again, CT is far superior in terms of detecting pneumoperitoneum. CT, of course, is also very good in terms of looking for other things inside the peritoneum or abdomen or perineum. For example, here, this was a man who presented with some vague thigh pain and perineum pain. On examination, there was nothing really much to see except for some faint rash over the scrotal area, but his pain was out of proportion to the external appearance of the rash, and so a CT was performed, and also because he was hypotensive, which showed extensive free gas along the perineum region, and this, of course, is Fournier's gangrene. And so here again, it really shows the power and the utility of having radiology available. If you did not have CT scan, this man may have had to have two ways of management. One, which is wait and see approach and give antibiotics. And the second may be just to take to the operation theater and do an open procedure just to look for exploratory procedures just to look for whether there's infection of focus around the perineum. CT, of course, is also very good at looking at solid organ abscesses, such as the liver. Here we can see a huge liver abscess. And also it can give information on whether they think the radiologist or the clinician interpreting the scan, whether the abscess is well formed, where is it, and whether it's got any liquefaction for possible drainage. And it's also important in terms of suggesting whether this is actually an underlying tumor or it's actually a tumor with an infected component. So CT, again, here is far superior to radiology, plain radiographs, which would not be able to pick up an abscess easily in the liver unless there was a clear air fluid level. CT imaging is also extremely helpful at looking at other parts of the body. For example, here, this was a man, again, presenting with thigh symptoms on the right thigh. And he's been having thigh pain for a couple of days with fever and rigors. And he actually had quite swollen right thigh. And externally, again, there was also only very minimal rash. But CT here shows that he's got a pseudoaneurysm coming off his thigh arteries, and also gas surrounding the pseudoaneurysm. And so this was and the blood culture subsequently came back as salmonella positive, and he had salmonella mycotic aneurysm of his right thigh. As mentioned earlier, CT or radiology is also extremely helpful in terms of establishing alternative diagnosis. And here we have an image of acute pancreatitis, which can present with similar symptoms to a liver abscess with abdominal pain, rigors, chills, hypotension, multi-organ failure, AKI. And so CT here can be extremely helpful in terms of looking at a non-infectious, or at least initially non-infectious, surgical abdomen. Of course, here you could argue that, well, you could take an amylase anyway, why do you need CT? But CT also has an extremely important role in terms of management of acute pancreatitis for multiple reasons. One, to confirm the extent of the acute pancreatitis. Two, to rule out biliary cause of the acute pancreatitis to see whether drainage is required. And three, serial measurements of the size and extent of the pancreatitis, and also looking for complications of necromas, of seromas, and also cysts would be extremely important to guide drainage, antibiotic therapy, and whether the patient can be expectantly managed without problems. And sometimes when we do chest CTs, we're looking for sites of pneumonia when the chest radiograph is not picking up an obvious infiltrate, but the patient is desaturating or has really bad gas exchange. And sometimes when we're doing for patients who have syncope or cardiogenic shock, we're looking for things like pulmonary embolism here, which may make a really sick patient with obstructive cardiac output and shock, cardiogenic shock, and or general respiratory failure, and you don't know why. CT here has picked up a acute pulmonary embolism affecting the pulmonary trunks. So other modalities which are also extremely helpful in terms of looking at the anatomy is magnetic resonance imaging and MRI. And so again here, similar to CT, it can provide very clear, detailed anatomy. It's got a much higher sensitivity and specificity, again, compared to radiographs. And unlike CT, there's no risk of radiation. There is sometimes a risk of ATI, but usually not if you select the right contrast to use. But one of the problems similar to CT is that it's not readily available. You need sometimes to wait quite a few days to get the MRI, or it may not even be available in low resource settings. You need to transport the patient to the radiology suite. So unlike a portable X-ray, you can actually have it on the spot. It's also quite important in terms of trying to get the patient stable enough for MRI, because a lot of our ventilators, syringe pumps, other supporting equipment such as IBP or ECMO would not be able to fit in the MRI suite because they all have metals which would affect the magnetic field and damage the machine if it gets sucked into the machine. And of course, it might harm the patient if these supports are temporarily turned off. So really, it's really for a select group of patients who can tolerate MRI procedure without a lot of fancy equipment or specialized, or at least have specialized equipment which are MRI compatible. And so it's sometimes difficult to provide this type of imaging when the patient is so unstable and needs so much support. And of course, if the patient also has MRI incompatible implants, that also precludes MRI imaging in the patient. But here is an image of the spine, and so MRI is extremely good at picking up things like cystitis or epidural abscesses, which this man has. Next, we move on to some point-of-care tests, which does not require transport. And of course, the most common one and most helpful one that we use now every day is the ultrasound. It's really a quick, non-invasive way to screen for places where we think there may be infection, or in general, indeed, even to screen for places for infection where we're not even suspecting, when we have limited history or examination findings. One of the downsides is that it's extremely operator dependent. It may also have very limited windows, and so not everyone will have a great image. And so the diagnostic utility of ultrasound is dependent both on the patient and also the person doing the ultrasound. Here we can see that there's a dilated common bile duct with a stone on the bottom image. And so this patient then went on to have RCP drainage to relieve the biliary obstruction. Other forms of ultrasound, of course, comes with echocardiography. It's a point-of-care test. It's extremely good at delineating the anatomy and function of the heart, and also tells you how well the heart is pumping. Again, it's non-invasive, but it suffers from the same problems that general ultrasound does. It's operator dependent, variable imaging, dependent on good windows, and also transthoracic echo may not be feasible or provide not good enough images, and therefore the patient may need a soft-gel approach, and that may actually be more invasive than other investigations to look for heart abnormalities or infection of the heart, such as cardiac MRI. And to complete our story, this is not commonly available, but this actually surprisingly came up on a lot of times in different studies in our scoping review of sepsis of unknown origin and investigative approaches, is PET scans. So PET CT is not widely available, but it is shown to be extremely sensitive to pinpoint sources of infection. One of the problems, of course, is it's extremely expensive as well, and also it's not commonly available in most hospitals, and sometimes you have to transport the patient to another hospital, which may not be feasible for someone who's extremely critically ill. Moving on then to other forms of radiology which are important in terms of treatment. Here we have a percutaneous nephrostomy, and so screening with radiographs to guide treatment and also to guide drainage is extremely important in terms of modern intensive care management of sepsis. Here, the patient had disseminated Staph aureus infection, and here an ultrasound probe is used to guide needle drainage into the right shoulder to aspirate an abscess which has formed around the shoulder joint in a patient with disseminated MSSA infection. So we've come to the end of this talk, and I'd like to provide you with some key messages that we've discussed today. Number one, the role of radiology is to help us identify the site of infection. And second is to assess the severity and extent of this infection, to help us also establish alternative diagnosis whilst we're treating someone with suspected sepsis, such as pulmonary embolism or acute pancreatitis, to help guide drainage of fluids collections and also abscesses, to help us monitor the response to treatment, such as the resolution of infiltrates, abscess size or extension. And also we've discussed the different modalities which are available, some of the pros and cons, and some of the common things that could be picked up by each of the modalities. I'd like to thank you once again for listening to my talk, and also to the Sepsis Pocketbook team, and also Continuous, and also Owen for giving me this opportunity to share with you some of my thoughts on the role of radiology in sepsis diagnostics and management. Thank you.